Colleagues, we have a quorum, and I'm calling the meeting to order. Now, as we are aware, we have 3 witnesses this morning, 2 of them presenting by video conference, and a third here with us live. Before I do the normal start of the meeting, I think I should first speak to Dr. Laupacis, who is on the video at the moment. Dr. Zamboni, we understand, will be arriving shortly. And Dr. Laupacis, thank you very much for joining us here. And once I get into the do the official start of the meeting, I will turn to you first, Dr. Laupacis, to start. Then if Dr. Zamboni has arrived, we will go to him, and then to Dr. Zivadinov. Am I getting closer? Thank you. So, honorable colleagues, with that, je vous souhaite la bienvenue au committee.
I welcome you to the Social Affairs, Science and Technology Committee.
A senator from Nova Scotia and chair of the committee. I'm going to ask my colleagues to identify themselves, starting on my right.
Judith Seidman from Montreal, Quebec.
Yana Martin from British Columbia.
Asha Sage, Toronto, Ontario.
Betty Unger, Edmonton, Alberta.
Tobias Inverga from Ontario.
Jane Cordy, I'm from Nova Scotia. I'm the sponsor of Bill S-204.
I'm Panna Merchant, and I'm from Saskatchewan.
Art Eggleton, Senator from Toronto and Deputy Chair of this committee.
Well, thank you very much, colleagues, and once again, thanks so much to our distinguished witnesses today for being with us. Two-thirds at the moment, and we hope to be complete very shortly. And so, Dr. Laupacis, I'm going to turn to you first. Would you please begin your presentation? And if I can learn to look in the right direction.
Hello, bonjour, committee members. In my opening remarks to you, I'll summarize the results of a study conducted by a number of Canadian researchers who have reviewed the scientific evidence from around the world about CCSVI and MS. CCSVI, as I'm sure you know, is an abbreviation for chronic cerebrospinal venous insufficiency. Our group has been funded to do this study by the Canadian Institutes of Health Research. There are 10 of us in the research group, and we have a variety of expertise covering multiple sclerosis, vascular surgery, neurosurgery, neuroradiology, statistics, epidemiology, and health systems research. Just a quick word about me. I'm a physician who practices palliative care at St. Michael's Hospital in Toronto. I would love to be with you, but I'm actually on the clinical service right now, so that's why I couldn't come up to Ottawa today. I'm also a researcher, and one of my areas of expertise is reviewing the scientific literature to assess what's known about the benefits and harms of tests and treatments. And I also have extensive experience with using such evidence to advise ministries of health in this country about which tests and treatments should be paid for by the publicly funded healthcare system and which should not. Our research group first released our report in June 2001, and we've since produced 2 updates, the most recent in June of this year. Our next update will be released next month in December. So let me briefly summarize the results of our findings to date. We focused our review of the scientific literature on what's known about 3 questions. First, is CCSVI, as diagnosed by ultrasound, found more often in people with MS than in people without MS? Second, what do we know about the benefits of treating CCSVI in someone with MS? And third, what do we know about the harms of treating CCSVI? So to the first question, as I'm sure the committee is aware, and Dr. Zamboni will be joining us shortly, he described an entity called CCSVI, which is an abnormality of the anatomy and the blood flow of the veins draining the brain and spinal cord. His initial paper indicated that CCSVI could be diagnosed using ultrasound, a non-invasive technique with no side effects. In that study, Dr. Zamboni reported that all patients with MS had CCSVI and that he could find no CCSVI in people who did not have MS. This is an exciting and astonishing finding. And it's astonishing because it's almost unheard of to have an abnormality that occurs in 100% of people with a disease and 0% of people without the disease. So after his study, a number of other people have done studies to look for CCSVI in people with and without MS to see if they could replicate Dr. Zamboni's findings. In our study, we identified all of the published studies that diagnosed CCSVI with ultrasound and compared the frequency of CCSVI in people with MS and in healthy people. And we found 11 such studies. And when the results of all the studies were combined, essentially when we averaged the results, we found that CCSVI was about 8 times more likely to be found in people with MS than in healthy people. However, there was a huge difference in the results among the studies, with some studies finding a much lower frequency of CCSVI than others. For example, one study found no CCSVI in any patients, whether they had MS or not. And some studies found actually no difference in the frequency of CCSVI between people with MS and healthy people. Now, in my experience, it's very unusual to find such a large difference in results among studies. And unfortunately, the reason for the large difference is not clear. What might explain the differences? Well, ultrasounds are very dependent upon their technique. For example, the results can be affected by how much pressure is put on the neck with the ultrasound probe, the position in which the patient is scanned, how the patient is breathing, and the experience of the person doing the ultrasound. So for ultrasound studies, it's also important that the people doing and interpreting the test are not aware of whether or not the person they're examining has MS, because this might accidentally influence their interpretation or reading of the results. It may well be that the differences in ultrasound technique and in the interpretation of the test cause the marked differences in the results of the studies, but we just don't know. So the bottom line from that first third of our review of the literature is the results of these studies are not conclusive. They neither prove that CCS is more common in people with MS than those without MS, nor do they prove that CCSVI is not associated with MS. In my opinion, such a wide variability in the results of the published studies of ultrasound for CCSVI means that this test is not ready for use in regular clinical practice. So the second question we looked at, the treatment for CCSVI is a venoplasty, basically dilating the narrowing in the vein with a balloon. Many people have reported a dramatic improvement in symptoms, often improvement in fatigue and strength and a feeling of increased warmth in the extremities after venoplasty treatment. Others have reported minor or no improvement. And after venoplasty, the narrowing recurs in the months after treatment in a considerable number of patients, between 30 and 45%. And this is an important thing to keep in mind. The only way to definitively establish whether CCSVI causes an improvement in the symptoms of MS, and if it does, to determine how big those improvements are and how long they last, is to conduct what's called a randomized trial, where in a randomized trial there's essentially a flip of a coin, and half of the patients undergo venoplasty and the other half do not. In the case of the randomized trial that Dr. Zamboni is involved with in Italy, my understanding is that they're using essentially a 3-sided coin, because 2/3 of the patients will get venoplasty and 1/3 will not. Unfortunately, no randomized trials of venoplasty for CCSVI have been reported, and therefore we don't know with any degree of scientific certainty whether venoplasty is beneficial or not. There are currently a number of randomized trials of venoplasty underway. I'm aware of 6 such studies, some of which are just getting started now. So it will be some time before the results of those studies are available. Finally, around the harms of treating CCSVI, doing a venoplasty involves inserting a catheter through a vein in the groin and passing it through the heart chambers and into the neck veins, where a balloon is briefly inflated and then deflated. A number of studies have reported the side effects caused by venoplasty. Some people get a headache, which usually gets better in a few hours to days. The most common serious side effect of venoplasty, which occurs in around 1 to 2% of patients, is an abnormal rhythm of the heart, which occurs because of irritation from the catheter passing through the heart. Although these abnormal heart rhythms usually get better, they can be very serious. There have also been reports of major bleeding from the blood thinners that patients are prescribed around the time of the procedure, some of which have been fatal. There have been instances of clots in the neck, leaking of the veins where the balloon was blown up, and stroke. In some instances, stents have been inserted as part of the treatment, and some have moved. sometimes into the heart, and this is why stents now tend not to be used when treating CCSVI. Thus, to summarize the harms of venoplasty, the majority of patients suffer no significant side effects. However, rarely there may be very serious side effects which can be fatal. So, given what we know about the benefits and harms of venoplasty for CCSVI in people with MS, do I believe that the public healthcare systems in Canada should pay for the diagnosis or treatment for CCSVI? I do not. I do not think there's sufficiently high-quality evidence to establish that the benefits of treatment outweigh the harms, or even that we can reliably diagnose CCSVI in routine practice, let alone research studies. So this has been an exceptionally brief summary of our review of the literature. All of our reports and publications are on a website, www.ccsvireviews.ca, and I encourage you and your staffs to visit it for more information. We also have a comment section on the website where you can leave comments or ask questions. So, merci, and thank you for the opportunity to present.
Thank you very much, Dr. Laupacis, and to remind my colleagues, you are on call this morning, and we do understand there is a slight chance that you may be called away, and we will recognize that. I will now turn to Dr. Robert Zivadinov, who is director at the Buffalo Neuroimaging Analysis Center and who has made a special effort to be able to get here to join us this morning, which we very much appreciate. Doctor, please.
Thank you very much. So, as you said, I'm director of the Buffalo Neuroimaging Analysis Center and professor in the Department of Neurology at the University of Buffalo, Buffalo, New York. Senator Ogilvy, members of the committee,
exchange here. We'll even out.
I'd like to thank you for this opportunity to speak about the state of the research relating to Senate Bill 204 and to provide what I believe is important perspective on the scientific and public debate on chronic cerebrospinal venous insufficiency. While I recognize that multiple sclerosis has appropriately provided the impetus for this public health discussion, I would like to commend the authors of this bill for taking a broader approach, namely for seeking to establish a national strategy for CCSVI itself. I'd also like to acknowledge the very significant contributions of my colleagues at the University of Buffalo, including Dr. Bianca Weinstock-Gutman, Adnan Siddiqui, Ralph Benedict, Murali Ramanathan, and many others for their collaboration in completing more than 25 studies on this subject. It may come as a very small surprise to you that as a research scientist, I'm here today to urge continuing commitment to the specific kinds of studies that will help avert risks and accelerate potential rewards to the public health relating to CCSVI in multiple sclerosis and other neurological disorders. As you know, after it was hypothesized that CCSVI is unique to MS patients, interest spikes and treatments were sought by and provided to patients here in Canada and around the world. These patients' risks and rewards became palpable, yet they have been supported primarily with media-reported anecdotes about both the science itself as well as patient outcomes. And I think you already agree that the managing public health through the media is not a prescription for success. Specifically, it is my belief that given the short and long-term risk related to use of stenting and medium to high risk for restenosis after venoplasty, CCSVI intervention should be restricted to blinded, randomized and controlled clinical trials that will establish the safety and efficacy of these procedures. While our research points against CCSVI having a primary causative role in MS, we have established that there is a higher prevalence of CCSVI in progressive MS patients. This suggests that CCSVI may contribute to or be a consequence of disease progression with important implications for treating its symptoms. In the next few minutes, I would like to explain why I believe there is a critical need to pursue studies on CCSVI to achieve three important outcomes. First, we must agree on our definition of diagnostic success, we must define and validate the spectrum of cranial extracranial venous anomalies and establish reliable diagnostic gold standards. This will require multimodal studies and improved test operator training. Second, we must agree on our definition of clinical success. There is a critical need to undertake controlled, randomized and blinded studies to first establish what clinical outcomes should be used in MSc CSVI clinical trials before we can assess endovascular treatment in terms of these outcomes. Moreover, we must close the yawning gap in CCSVI prevalence estimates, as you heard from previous presentation, that range from 0 to 100% depending on the population, the methodology, the criteria and the imaging technique. Then, based on valid diagnostic and clinical measures, we of course must determine the efficacy of endovascular treatment itself. These are three discrete steps. Determining the efficacy of endovascular treatment will require placebo-controlled trials using more advanced imaging techniques with a larger number of patients. It is significant that, notwithstanding our initial focus on MS, the science invites us also to explore whether CCSVI is a syndrome characterized by symptoms such as headache, fatigue, sleep disturbances and autonomic dysfunctions that can be improved with endovascular treatment, and secondarily, what treatment outcome constitute efficacy for such procedures. Let me briefly address important challenges in arriving at valid diagnostic measures. Veins have a tendency to collapse and change their morphology and size in relation to multiple factors that can vary during testing. And while radiologists generally know how to perform their diagnostic imaging and intervention, there are no standardized guidelines for detection of abnormalities indicative of CCSVI. In our view, there is a need both for standardized extracranial and transcranial color Doppler training, which assesses morphologic and hemodynamic parameters, and detection of venous and intracranial and extracranial abnormalities by using multimodal imaging approach studies. Because of the complexity of the intracranial and cervical venous system, it is almost impossible during testing to take all of these key factors into account, regardless of which single imaging modality is used. Therefore, multimodal imaging approach is necessary. In my remaining time, I would like to focus on the key issues associated with clinical outcomes. Contrary to the earlier mentioned hypothesis, studies show CCSVI is not exclusive to MS patients. Yet more recent studies have questioned the very existence of CCSVI in MS patients. This dramatic disparity must be explained before any exploration of treatment is possible. In my view, the explanation may lie in the assumption built into most of the research to date that the diagnosis of the CCSVI is either positive or negative, yes or no, with no allowance for variability or gradations of severity of these abnormalities in the result. Our recent blinded study sought to reconcile these disparate findings by examining CCSVI prevalence in the larger cohort of MS patients to date, in patients with other neurological diseases as well as in healthy controls, using multimodal imaging approaches. By using echo-color Doppler standardized in expert hands, we found that CCSVI was present in 56% of MS patients. It was present in 42% of other neurological diseases. It appeared in 38% of patients at first clinical attack, so-called clinical isolated syndrome, and we also found CCSVI in 22% of healthy controls. MS patients with CCSVI showed significantly lower net cerebrospinal fluid flow and brain perfusion, findings which were highly associated with severity of CCSVI compared to healthy control and MS patients without CCSVI. Despite this pilot data, more evidence is needed to establish the association of CCSVI and MS. More recent results that I presented last October at the European Committee for Treatment and Research in Multiple Sclerosis in Lyon, France, showed that the prevalence of CCSVI in those with other neurological disorders is as high as 54%. The fact that patients with other neurological diseases and healthy individuals also present with Ccsvi in significant percentages underscore a legitimate question regarding whether endovascular treatment for Ccsvi is necessary, whether should be restricted only to MS patients, or whether other individuals with Ccsvi should also be considered. I know you will understand how hard it is for me to limit my comments to 7 minutes and leave out the many details that support my conclusions, but let me summarize now what I believe to be the next horizon for Ccsvi science as it relates to MS and other neurological disorders. It is essential to acknowledge that the health benefits of endovascular treatments for Ccsvi cannot be assessed before we properly understand who is affected by Ccsvi, whether the treatment is necessary, and finally, what is the optimal treatment outcome and type of procedure to be used for determining efficacy of the treatment itself. We believe that current evidence for association between Ccsvi and MS justifies blinded randomized control phase 1 and phase 2 clinical trials to assess the benefits of endovascular interventions. This should be done according to established clinical, MRI, quality of life treatment outcomes, employing safe and ethical approaches. If an initial benefit for endovascular therapy is established, then properly powered phase 3 trials should be conducted to determine whether this treatment can be made widely available. Moreover, I believe it is time to expand the discussion of Ccsvi treatment beyond MS to other neurological disorders. Until these steps are accomplished, I believe there is no role for endovascular treatment of Ccsvi in MS patients or in patients with other neurological disorders outside of approved and carefully designed clinical trials. Fortunately, we know what studies need to be undertaken, we know their implications for improving the public health, and we know how they should be conducted. Only time and, of course, funding will advance the moment when this answer can materially improve the lives of patients with MS and those with other neurological disorders. Thank you.
Thank you very much. Now, colleagues, Dr. Zamboni has not arrived yet, and I should inform you that it's a holiday in Italy today. It's All Saints' Day, and he has been driving some distance to get to the only conference center that we could arrange on a holiday for him to be present at, and clearly there's been some delay. I'm wondering if you would agree that when he arrives, we will complete the answer to any question on the table and then move immediately to Dr. Zamboni. Would that be agreeable? Thank you very much, colleagues. So with that... no further comment on that. And so now then, to our guests, our witnesses, I want to thank you for your presentations, and I'm going to open up the meeting to my colleagues, and we will proceed with the questions until Dr. Zamboni arrives. And so my list will start with Senator Cordy, to be followed by Senator Eggleton, and then Senator Seidman. Senator Cordy, please.
Thank you very much, Chair, and thank you to both witnesses who have appeared today and given us your feelings about Ccsvi and the treatment for Ccsvi. Bill S-204 speaks about developing a national strategy for multiple sclerosis for Canada. It also asks that we have collection of data from those who have had the procedure outside of the country, so that we can collect information in Canada about Canadians. It also asks for follow-up care, because I've certainly heard from hundreds of people who are very concerned that when they return from having the treatment done outside the country and they come back to Canada, that they are not allowed to have follow-up care. The bill also spoke about starting clinical trials. Fortunately, the government has announced clinical trials. In fact, the date was November 1st, which is today, so I guess that's a day to celebrate the start of clinical trials. So in fact, Canada is starting clinical trials to look at gathering information, made in Canada scientific information, and that's what we want. Dr. Laupacis, you spoke in great detail about the rate of complications. When Dr. Baudet was here, he spoke about the clinical trials that are happening in Albany, New York, and he talked about having discussions with the clinic in Albany. And Dr. Gary Siskin is one of the people who works in that clinic. And in fact, Dr. Siskin talks about the rate of complications as a result of the venous angioplasty treatment as being 1.6%. That certainly differs with the information that you gave us today. So I wonder if you would comment on Dr. Siskin's rate of complication of being 1.6%.
Dr. Laupacis.
Yeah, thanks. Maybe I didn't make myself clear, but the rate of serious complications that I quoted was actually between 1 to 2%, and Dr. Siskin's group's results actually were very influential in informing that. So I don't think we disagree in terms of serious complications. The rate is very low.
Thank you very much for that clarification, because that wasn't the message that I got when I was listening to you. So I thank you very much for that the rate of serious complications would be between 1 and 2%. So thank you very much. I wonder, too, you made, when you were speaking, you spoke about some deaths, some strokes. So I wonder, do you have any numbers for that, about the number of deaths and the number of strokes?
No, I think, unfortunately, that's a real limitation of the studies that have been done. I mean, my sense is that many clinics who provide this procedure provide it to individuals who come from a long distance away, and they don't actually do a particularly good job of following all of those patients, so that they, clinic in Costa Rica might do a large number of venoplasties in people around the world, and they frankly don't know how those patients do when they leave their clinic. So I think that's a huge, I suspect the serious complications may be higher than is being reported, because the studies don't routinely follow patients for a long time.
And that's why I think that I feel the importance of this bill is that we collect data from those who have come, Canadians who have had the procedure outside the country and who come back. I think it's important that we collect that data. I'm wondering also, you spoke about your website, Ccsvi Review, which is funded by CIHR, and you respond to patients who inquire about the Ccsvi treatment, and I'm wondering whether or not you've ever observed the Ccsvi treatment taking place, and what your area of expertise is in terms of actual practice or observation of the procedure.
Dr. Laupacis.
So let me address a number there. Well, I'll address the last one first. I'm, as I said before, I'm a general internist and palliative care physician. The procedure is not provided in Canada, so I have not seen the procedure. Having said that, I do have lots of experience in evaluating the scientific literature for a number of procedures, outside of MS. Your comment about the benefits of a study that would follow patients when they come back from elsewhere having had the procedure, I agree with you completely that will give us a much better estimate of what the serious complication rate is of that procedure. Because if someone comes back and 3 weeks after the procedure they have a big hematoma in their neck, it's pretty obvious that it was due to the procedure. On the other hand, in my opinion, and I'd agree with Dr. Zivadinov, that I don't think that kind of study is very helpful in helping us figure out whether the procedure actually works. Because in order to do that, especially to assess the really important symptoms of patients such as fatigue and warmth, I think you need a control group, and I think you need a randomized trial.
And I would agree with you, we need the trials, but I think it's important that we also gain some information from those who have had the procedure done outside the country, whether it's been effective or not effective. But I do agree that we need the clinical trials, absolutely. Dr. Zivadinov, I know that you've said, you've been quoted as saying, if we can prove the hypothesis that CCS is the underlying cause of MS, then it's going to change the face of how we understand the disease. I wonder if you would explain that a little bit further, please.
Yeah, that was a very initial phase when we started a pilot study with Professor Zamboni, and in that pilot study there were 16 MS patients, both half from Buffalo and half from Italy, and 8 healthy controls, and in that study the prevalence was 100% in MS patients and 0 in healthy controls in that particular pilot study. Based on that, we started a large cohort study that was published. The phase 1 was published and included 499 subjects, including MS patients, healthy controls, patients with other neurologic diseases, and patients at first clinical attack. We continued that study, and actually, as we speak, we are locking the next 500 subjects in the study. So the study has now over 1,000 subjects, and the first part of the second phase data have been presented at ECTRIMS. As I mentioned, this was a study of 234 healthy controls versus 78 patients with other neurological diseases, where we established that there is a significantly higher prevalence of CCSVI in patients with other neurologic disorders. These neurologic disorders have been divided in 4 groups: neuromuscular, neurovascular, neurodegenerative, and neuroautoimmune. And in each group of these 4 big groups of particular neurologic disorders, there have been several different diseases in each group. So to give you an idea, for example, in our neuromuscular group, there was a myasthenia gravis, polyneuropathy, etc. And we found very similar prevalence of CCSVI. I would say that our earlier data, as well as this new data that are not yet published, but that are very presented at ECTRIMS and that I'm sharing with you, suggest that CCSVI is not the cause of MS, but it's probably a consequence. And I think that for this panel, one of the fundamental things might be to understand why patients with neurological disorders who are more disabled, less mobile, are suffering more from higher prevalence of CCSVI. I would say that nobody knows that reason, and maybe our group is the only one until in the world that published 2 risk factor studies for CCSVI. For the record, one was published last November in PLOS ONE journal, and the other one was published a couple of weeks ago in Neurological Research. Both studies have been done on approximately 250 healthy controls and evaluated a range of different factors that lead to the increased prevalence of CCSVI in healthy people. And both studies have been very similar in their conclusion that cardiovascular risk factors, heart disease, obesity, and overweight, and smoking have been most important risk factors for CCSVI. So that would tell you that people who probably move less because they are disabled, they have a tendency, as we already know in neurological disorders, to develop more of these cardiovascular risk factors, overweight, etc., and they probably consequently develop more of CCSVI. And the tricky point starts once you develop the stenosis of these veins, because you are less mobile, you are more disabled. What does that mean for your underlying disease if you have a neurological disease? Or what does that mean for you as a person, as a healthy individual, if you have a CCSVI? And so our recent studies are moving in 2 different directions. In healthy individuals, we try to understand hemodynamic and structural changes of the brain if you have or you don't have a CCSVI. My personal opinion is that this is a research that will continue for decades and might be an important answer to many as a risk factor to many neurodegenerative diseases that we know these days are really a very big burden to the public health system. The second point is, what does that mean to the neurological disorders? We have data from a large study of about 300 plus MS patients, and we found that patients who have more progressive disease, which means they are more disabled, more in a secondary progressive or primary progressive phase, they are suffering more from CCSVI. And respect to your initial comment, sorry for this long answer, we can't say whether CCSVI was the contributing factor for the secondary progressive disease or was a consequence. And this is definitely something to be explored in longitudinal studies.
Just a quick question. I wonder, you spoke today a lot about multimodal imaging in order to determine whether or not there is CCSVI in the patient, MS patient or non-MS patient. I wonder if you could give us, I heard a presentation that you gave a while ago, and I wonder, you spoke during that presentation about the positive and negative studies and what you tended to find about those that were positive and those that were negative and who was publishing which studies. And I wonder about those positive and negative studies, if in fact they used multimodal imaging, which is what you certainly were proposing to do.
Thank you very much, Senator, for this question, which I think is central, really, to this debate. As you know, the prevalence is, as I mentioned, range between 100 and 0. So this is truly, amazing that nowadays with all the advanced imaging techniques, somebody can say it's 100 and somebody can say it's 0. I think one of the key elements of the diagnosis of CCSVI is the fact that a patient or a subject has to fulfill two extra or intracranial criteria. From my experience on thousands of examinations we did, those patients who have 3 or more than 3 criteria are really in a low 25 percentile. So most of the patients have 2 criteria or between 1 and 2 criteria. Now, the criteria number 2 of the Doppler is the one that it's looking on the intracranial reflux, deep cerebral vein reflux. In most of the negative studies, they report that this criteria is 0. So basically, what they are left with is 1 positive criteria, and they say there is no CCSVI. So I'm telling you this in very simple terms. But if you go and look the published papers, those that report 3% or 0% or 5% or 16% of CCSVI, and you look how many patients or how many subjects have had 1 or more than 1 positive criteria, you will see that there is between 30 to 50% in all studies that have been published up to date. So I definitely disagree with many of my colleagues who are saying there is no CCSVI. Yes, there is no CCSVI in your hands as a categorical diagnosis, yes, no. But as I mentioned in my statement, this is a problem like, let me give you an example. When you have a carotid stenosis, right, and you have plaques, you are not going to show symptoms until you have 70% of the stenosis. Only when you have 70% of the stenosis, you are going to begin show, transitory ischemic attacks and stroke and similar things. So this is very similar, I would say, in the veins. You have certain stenosis in percentages, and it's very much more difficult to determine that in veins, and we need to understand at what hemodynamic point of the stenosis there are clinically associated symptoms which could worsen the underlying disease or contributing to susceptibility of the new disease. So I would say that Doppler in expert hands is a probably very good screening tool, as we proved it and reproved it through multimodal imaging, but in other hands may not be as good. And so in order to standardize the diagnosis, I don't think we will be able to use one imaging modality, but we will need to confirm with 2 or 3 non-invasive imaging modalities what we are finding. If you just do the simple MRV, which is magnetic resonance venography of these veins, you are going to find that progressive MS patients have about 50% of these veins stenosed, which is decreasing definitely in those to 25% who are not as disabled. And we found that 15% of the healthy controls have these problems on MRV. As a end-of-the-line type of diagnostic standard could be the use of what is really a next step in science, and that's called intravascular ultrasound. We just also presented at ECTRIMS the first intravascular ultrasound studies in patients with CCSVI. That means that we entered with the Doppler into the veins of MS patients and showed that there are more abnormalities than we see with so-called gold standard catheter venography. So I would say that if you think many people here on the committee and in general said catheter venography is a gold standard, but we are saying no. If you do even more sensitive tests than catheter venography is like intravascular ultrasound, you are going to see more. And so my point is that because of the controversy that has been created, and because now of tendency to report CCSVI presence of 0, although 30 to 40% of patients may be suffering with some grade of severity of their vein stenosis, I think we should assess these problems with more than one non-invasive imaging test.
Thank you very much. Senator, I've got a long list now, and I'd like to turn to your colleagues. Senator Eggleton.
Well, I'm glad the clinical trials are getting underway here in Canada because obviously there's some unanswered questions and some doubts that need to be responded to, and hopefully those studies will help to clarify a number of issues. Dr. Laupacis, you said that in summary that the harms of venoplasty, the majority of patients suffer no significant side effects. But you said, however, rarely there can be very severe side effects which can be fatal. And in the questioning with Senator Cordy, you mentioned that perhaps it's between 1% and 2% we're talking about. Well, now, previously at the committee, we talked about some of the drugs that are prescribed for MS patients. And there were also some severe side effects we were being told with respect to those drugs, and some fatalities as well. How does this procedure compare to the drug problems that may occur for side effects with a number of people?
Dr. Laupacis.
Thanks, Senator. I guess my main comment would be that the difference about what we know about the drugs and what we know about venoplasty for CCSVI is that the drugs have been submitted to high-quality randomized trials, many of the times with a couple thousand patients. So no question the drugs cause serious side effects, but we actually know what the benefits of the drugs are from randomized trials. And, my summary of the evidence from the drugs is that none of them are a home run. None of them cure disease, but they do appear in a subset of patients, particularly patients with relapsing remitting disease, to provide some benefit and quality of life. So my response, Senator, would be if I knew about the side effects of the drugs and had no idea about the benefits of the drugs, I would also be saying the drugs should not be provided by the publicly funded healthcare system. I think where we're at now with the drugs, we do know the benefits and risks, and patients can make their own mind up about whether they wish to take the drugs, given what we know about their benefits and side effects.
Your closing comments seem to indicate that you're rather negative about the possibility here of this endovascular treatment for CSSVI. Are you still open-minded about this thing, or have you decided that there's not going to be any great value to this particular procedure?
I think if you look, Senator, at things I've written, I was calling for randomized trials about 2 to 3 years ago. So, listen, I've been in the healthcare system for 25 to 30 years. I've seen things that we really hoped would work be just as good as we thought they would be. I've seen things that we thought would work turn out to do more harm than their benefits. So, I'm a very strong believer in the need for evidence before introducing treatment, both for patients and also, frankly, for our healthcare system, which is pretty strained. So I would be delighted if the randomized trials showed a benefit of the treatment. And I've been at this long enough to know that often the results surprise us.
Okay. Perhaps Dr. Zivadinov might have some further comment on that. And also, I'd also like to know, we're talking about starting these trials here. Surely there have been trials in other parts of the world. Is there anything you can enlighten us with in that regard?
So I agree.
No, actually, there are not. As I said, there are 6 trials underway that I'm aware of in the world, 6 randomized trials. One of them, Dr. Zamboni is involved in, which is actually the largest trial, so over 600 patients in Italy. It's just getting underway. And there have been some trials underway in the U.S. for quite a while, and we've not heard, they've obviously not come to a conclusion. So there are no randomized trials of treatment for CCSVI reported in the world to date.
Okay. Dr. Zivadinov.
So many probably of you know that in Buffalo we did 2 studies, 2 trials. One was a trial with Professor Zamboni that was published this year, and this was not randomized trial. In which we evaluated 15 patients, 6 as a delayed arm and 7 as a delayed arm and 8 as an immediate arm, and we saw some small benefits, but clearly it was not a randomized trial. As a consequence of that, we embarked in a study called PREMIS. It's a prospective randomized placebo-controlled trial for MS. 30 patients have been enrolled in that study, 10 patients in phase 1 to test the safety and eligibility of the procedure, and then 20 patients have been randomized to the sham, which is placebo or treatment arm. They have been followed for 6 months with assessment, very vast range of assessments at 1, 3, and 6 months. These data have been locked, and we will soon, they are under statistical analysis, and this data will be probably soon known. I think it's the first placebo-controlled randomized trial that has been done. I would like to bring to attention to this committee a couple of important points regarding treatment outcomes, because the studies that have been done until today, they looked on a self-reported quality measures of the patients. I feel better, I feel not better. So you need to kind of think that when we talk about MS clinical trials, and I have been involved for more than 15 years in doing MS clinical trials, and I am really an expert, recognized expert in doing MRI readings for biggest phase 3 trials in the world. You need to have objective measures that are going to determine whether this treatment or not can decrease the number of relapses in MS, can decrease the number of new T2 lesions and gut-enhancing lesions, and can promote the quality of life. That's all what we collected in our study. I would say that it's, in my opinion, as I mentioned here, a little bit premature to organize the studies on 6,000-7,000 patients or 1,000 patients until we don't know in a smaller placebo-controlled trials up to 100 people, 100, 150, 200 people, which are called phase 1-2 studies, whether there is clearly a positive sign to conduct larger randomized controlled trials. Let's not forget that in any drug development there are certain steps that you must follow, and one first step is after there has been some positive sign, which I think it was, both from the patient self-reports and for some studies, the open-label studies that have been done, you need to begin to phase 1-2 randomized controlled trials, and then based on these results, power the studies to conduct. And I would say that as maybe through the words you did not grasp enough, but I was referring that there are treatment outcomes specific to MS, clinical MRI quality of life. But what about treatment outcomes specific for CCSVI, which might be decrease of a headache, decrease of fatigue, decrease of sleep disturbances, improvement in those symptoms? Should we create treatment outcomes to be used in these studies that will evaluate, let's say, if you do a surgery on a Parkinson's disease patient, maybe he will improve in fatigue and headache and sleep disturbances. So I think that we are talking really about two types of clinical outcomes here, one related to MS and one in general to CCSVI.
Okay, thank you. I see Dr. Zamboni has just arrived, so as per agreement, we will turn to him, and when he has completed his study, I will go to Senator Cordy first, and if she would limit her questions, because I want to get to our longer list, and then I will return to the list as I have it and continue with the senators who have not asked questions. Is that acceptable to you, colleagues, as a procedure? Thank you. Dr. Zamboni, can you hear me?
Yes.
Well,
thank you.
Thank you very much
sorry,
for. We know that you've had a long journey just to try to get to a site this morning or today that where you could join us. We want to thank you very much for an extraordinary effort on your behalf to be able to be with us. We have two other witnesses, as you know, with us who have presented, and we have been in the questioning. By agreement, we agreed that once you arrived, we would turn to you to make your presentation. We have copies of the presentation that you provided to us. So I would now like to turn to you and have you present to us. Dr. Zamboni.
Thank you very much. I try to focus some points that, in my opinion, are very important to encourage and or revise study on CCSVI pathology, because one of the points is that there is someone who questioned the existence of stenosis or significant stenosis in vein, but in my opinion the benchmark in medicine is still histology and pathology, and so we have now two different studies, one of gross anatomy done in Cleveland, Ohio, showing clearly that there is in people who died with MS a significant number of intraluminal obstacles found macroscopically in their jugular vein respect to controls. And also histology clearly shows us that there is a marker in the vein wall that is type 3 collagen that is much more represented in people with CCSVI respect to specimen coming from people without problem of CCSVI. So this is a very important point, because also the last study clearly show that there are no T lymphocyte infiltration in the jugular wall, So cannot be an epiphenomenon of autoimmune reaction linked to MS, but this kind of malformation are completely independent because the inflammatory markers are equally distributed in tissue coming from Ccsvi and in tissue coming from controls. Also, science is increasing evidence also of markers, genetic markers of Ccsvi. There is a study showing clearly that on chromosome 6 in the HLA locus, so very close to the locus showing susceptibility to MS, there is a number of mutation, and the number of mutation is linearly related to the chance of developing malformation in the veins. This is very interesting because also shows us that the HLA locus is not linked exclusively to immunity, but also to angiogenesis and to several other regulatory functions. There is a study coming from Buffalo, a very large study, showing specific environmental factors linked to Ccsvi. They found clearly the presence of heart disease, especially heart murmurs, stories of infection, and irritable bowel syndrome are linked to the presence of Ccsvi. So there is a lot of accumulating evidence in showing how Ccsvi is something to be inserted in the current nosography in medicine. Showing the epidemiology, one of the major problems is linked to Doppler sonography because our initial proposal to establish criteria based on qualitative Doppler sonography showed some problems because there are a lot of confirmatory but also not confirmatory study linked with the operator dependency and the training dependency of this kind of system. So I think that now the majority of people who are interested in Ccsvi diagnosis is much more oriented in considering multimodalities for diagnosis of Ccsvi, including Doppler, including MRV, including venography. What I show also is something related, for example, to the recent COSMO study. Is a very important study, a blinded study by using ultrasound, and showing no Ccsvi in MS, and also no Ccsvi in normal people with very different rate respect to what is normally published. The problem is that 90% of Ccsvi recording found in the peripheral centers were cancelled at the central level by 3 independent lectures. So this kind of study really does not replicate our seminal study because we found Ccsvi by comparing color Doppler and a catheter venography. So there was an agreement in this. So hemodynamic problem and morphological problem. In this kind of study, we have color Doppler performed blinded at peripheral level, not confirmed in agreement, so versus agreement, not versus venography by central lectures. 90% of false positive clearly indicate that our methodology was not followed, or probably our methodology is not reproducible, but this not prove the absence of Ccsvi. There are a lot of other studies that in contrast showing prevalence and good reproducibility when proper attention to sonographer training was given. we propose a more objective, non-invasive, cost-effective system for screening Ccsvi. This needs actually just to ameliorate the evidence by using a multi-center trial, but this kind of system is cervical plethysmography, is a system capable to detect the venous outflow by changing in posture, is a very objective, simple method, really cost-effective, with a concordant rate with other methodology of 84%, and based on this, the Italian Ministry of Health funded a study to verify the potentiality and reproducibility of cervical plethysmography in Ccsvi diagnosis versus MRV and color Doppler in a multicentric fashion. Catheter venography is, of course, invasive, is probably not the gold standard, but is the best probably we have now. And study by using catheter venography clearly show in a rate often greater than 90% there are Ccsvi in MS. Studies are 13 published, and they came from 8 different countries, and so it's very impressive the number of abnormalities seen by catheter venography. That probably is a more objective and less debatable system. MRV, you know, is non-invasive, but unfortunately is a low sensitivity system. Now seems to be more useful, not in imaging, but in flow detection. Very interesting because this is an objective measurement by two-dimensional magnetic resonance image and the flow measurement. Especially flow measurement seems to be a very sensitive system to elucidate the presence of Ccsvi. I think that a good strategy could be to use screening like cervical plethysmography, and after this to confirm Ccsvi by using multimodalities, MRV, color Doppler, and also catheter venography in case. This could be the future agenda in Ccsvi diagnosis. Cervical plethysmography, I think that is a very promising technique, and also give us the opportunity to measure something that can be corrected by surgery or by endovascular procedure and can be monitored very easily in the future. The last step of the strategy is to properly investigate the safety and the effectiveness of Ccsvi treatment. In my opinion, now we have, of course, very few data in this field because we have simple observational or case control study, very limited in number. And now we have 4 ongoing double-blinded clinical trials. One is Premise that probably will be mentioned by Robert Zivadinov. Now we are recruiting patients in a very large double-blind and randomized control study in Italy, completely funded with public fund. This study has a very strong methodology because we objectively investigate the physical performance and also the mental performance of people at baseline and along the follow-up. There are also other studies with this kind of design, and we think that this is for sure the path to follow in order to accumulate evidence about the possibility to improve the condition of MS sufferers with, by adding also a solution to the venous problem. There are also increasing evidence that this kind of procedures may change something in the brain pathophysiology, especially in brain perfusion and in cerebrospinal fluid flow. And these are very important points, but I think that I see also Robert Zivadinov, but he is probably the best investigator to refer about this new kind of evidence. Thank you very much.
Thank you very much, Dr. Zamboni. And as per our agreement, I'll get Senator Cordy to ask a key question, and then I'll move to our colleagues and come back to her at the end if she has more questions.
I'll just ask very quickly, Dr. Zamboni, there has been a lot of resistance to your theory. I'm wondering if you could briefly tell us about that and who leads this resistance. And secondly, at our last meeting of this committee dealing with Bill S-204, we talked about the COMI study that's funded by the MS Society of Italy. And I know that you opted out of that study, you left that study, and I wonder if you could give us your reasons for not being part of that study.
Dr. Zamboni.
Yes. Regarding the second question, I decided to abandon the steering committee because there was no agreement between the investigator about the training of the people chosen for investigating the MS and the healthy controls. So I asked simply to train the people because also the main investigator were not very expert in this kind of color Doppler investigation, but there was no possibility to change the design of a national MS society. So I was very, very disappointed on this, of course, and also very sorry, but there was no possibility to change the decision to be the main trainer of the investigators. And so I also I was also present at different sessions of training, and I was completely not in agreement with the concept and the system of interpretation of the color Doppler findings. So there was no agreement between me and between the main sonographers of this kind of study about the interpretation of the finding. And this is very clearly depicted in a recent statement of the European Neurosonology Society, where my proposal of interpretation of the duplex response to the investigation are completely different from what was proposed by me, but also my proposal was in agreement with 7 different vascular societies who participated in a consensus conference. So I think that this is a major controversial point because duplex probably is not the right system to investigate in people with MS in order to have right epidemiological data. And this is, to answer the first question, probably the main point of the controversy. Is duplex is not a good system, there are controversial results, and this obviously determine shadow about the presence of Ccsvi or not.
Doctor, I'll now turn to my list, and we will start with Senator Seidman, to be followed by Senator Merchant, to be followed by Senator Seth. Senator Seidman, please.
Chair. And thank you so much to all of you for appearing before us today. Your knowledge and experience is invaluable to us as we study this proposed legislation. When Senator Cordy testified before this committee, she told us that about 75,000 Canadians live with multiple sclerosis and that each year an additional 1,000 are diagnosed. This is an extremely cruel disease that disproportionately affects Canadians, and we all want the same thing: the best scientific evidence upon which medical decisions can be based. This is what Canadians expect and what they deserve. In Canada, we're about to begin the recruitment of patients to participate in a Phase 1-2 controlled, double-blinded clinical trial to test the safety and efficacy of Ccsvi. This clinical trial will involve 100 MS patients with the intention to carry out the trial in 4 different sites. So, as we move forward with our own trials in Canada, there continue to be a number of voices of caution raised, both internationally and here at home. For example, the Multiple Sclerosis International Federation recently released this statement, quote, "The risks and benefits of procedures to treat Ccsvi have not been established by properly controlled clinical trials. Unless and until strong supportive evidence is produced, and until the risks of treatment are thoroughly assessed, any procedures to mechanically correct the purported problem outside of a clinical trial are not recommended." I would appreciate your comments on this statement. More specifically, what role clinical trials play in clarifying our understanding and in ultimately giving MS patients the answers they deserve. For all of us and our listening audience who may not fully understand the scientific credentials of clinical trials, might you explain why you both stress the critical importance of doing clinical trials? And here I'm referring to you, Dr. Zivadinov, and you, Dr. Laupacis, who we both heard before you arrived, Dr. Zamboni. And in fact, in your presentation, Dr. Zivadinov, you stated that Ccsvi intervention should be restricted to blinded, randomized, and controlled clinical trials that will establish the safety and efficacy of these procedures. And you went on and said, given the current state of knowledge, there is no role for endovascular treatment of Ccsvi in MS patients outside of approved clinical trials. So, in this very long-winded way, I'm asking you to help everyone, all of us here, and our listeners, understand the importance of clinical trials. What do clinical trials offer us? What is the methodology of clinical trials offer us that's different from anything else? And why can we expect the kind of results we're all hoping for?
Okay, I'm going to go to Dr. Zivadinov first and then to Dr. Laupacis, and that question could be answered in a 3-hour seminar, or but you need an answer before this committee. So if you can both constrain your extent of the answer, but still try to convey the correct answer.
1 minute answer. I mean, blinded treatment trial, placebo-controlled, is kind of a state-of-the-art how we determine whether the efficacy of any drug or procedure is good or not. So in terms of MS, particular primary and secondary and tertiary endpoints have been established in controlled randomized trials. Usually the primary endpoints are delay of disability over 2 years. Secondary endpoints are number of relapses that are occurring over 2 years, or number of new T2 or gadolinium enhancing lesions. Another very important endpoint in clinical trials in MS is development of brain atrophy. These 4 outcomes are kind of essence of conducting clinical trials in MS. As probably you know from what has been said today and in the past, neither one study on Ccsvi evaluated until today, except maybe our study with Professor Zamboni, which was not randomized and blinded, these endpoints, but quality of life was assessed, which I concur. It's a very important point for MS patients, but it's only a tertiary endpoint in clinical trials. So we must understand, is Ccsvi a treatment that's going to help disease modification, or is a treatment that it's a symptomatology treatment for treating headache, fatigue, sleep disturbances, etc. Once we determine that, we need to understand, is the risk worthy of the treatment to improve the headache, fatigue, sleep disturbances, quality of life, if there is no effect on disease modification. I think this is the essence of the problem.
Thank you. Dr. Laupacis.
Yeah, I guess I would address the question in two ways. The first one is why do a randomized trial? And I think you very eloquently described the very dire situation that many patients with multiple sclerosis find themselves and their families. And there's therefore an understandable wish on the part of patients and the physicians that treat them when they get a treatment to think and hope that it'll work. And therefore, there's what's called a placebo effect, not just in the treatment of multiple sclerosis, but almost any other disorder where if a patient gets something that they think they're going to work, a few of them on average feel that it does work, and if you gave them a placebo, or in this case a sham venoplasty, you might show the same benefit. The second thing, I guess, with multiple sclerosis, with the subset that have relapsing remitting disease, some of the patients after a relapse will just spontaneously get better. And if they had a venoplasty around the time they were spontaneously getting better, they might think it's due to the venoplasty. Obviously, that's not an issue with people with progressive MS. So to summarize, in terms of really knowing for sure whether any benefit that's reported is due to the treatment, you do need to have a randomized trial. And some people see that as a way of slowing down access to the disorder. Frankly, I think if well-done randomized trials showed that venoplasty actually improved any of the outcomes that Dr. Zivadinov talked about, whether they're quality of life or MRI, I think that would markedly increase the chance that people would say, as he just said, that patients should be able to weigh the risks and benefits and decide whether they want the treatment. The only other comment I'd make is with I don't think we should be Canadian-centric. If Dr. Zivadinov, Dr. Zamboni in 2 years, if he and his colleagues report the 2 or 3 years, the report of their Italian study before ours in Canada is done, we should be accepting all high-quality evidence from around the world. And maybe one of the things that would be great would be if the people that are doing the various trials would collect information on the same outcome measures so the results of those trials can then be combined when they're done. Because my final comment is that often, one trial, or almost never is it that one trial answers all the questions one wants and wants to have answered. And being able to combine the results of the studies once they're reported would be incredibly helpful.
Dr. Zamboni, do you have anything to add to the two comments on this specific question?
It's very important. Yes, I think it's very important, the last point, because probably in the trials we need to use comparable measure. For instance, Robert mentioned T1 and T2 active lesion, or number and volume of new T2 lesion by MRI. This is clearly something that can be done in all the trial. But also we developed an interesting system to give a picture of the disease. It's based on 5 physical function, that can be measured objectively by instrument. I think that this is a very important methodology that can be also shared with other clinical trials. This is very important because it has to compare by meta-analytic system the different results in the different double-blinded randomized control trial.
I'm sorry I interrupted you, Dr. Zamboni. Thank you very much. I'll now turn to Senator Merchant.
Thank you all so much. I'll be quick. Dr. Zivadinov, is there a difference in the results of studies depending on whether the study is done by a vascular specialist or by a neurologist?
Thank you for this kind question. I think there is. I think that most of studies done by neurologists have been negative so far. Most of the studies done by the vascular surgeon have been positive so far. Now, you can even look that in a different way where the studies have been published. Most of radiological vascular journals are reporting positive findings, and most of neurological journals are reporting negative findings. What's the reason for that? I don't know, but my opinion is that I strongly believe that every scientist and researcher is truly reporting the findings that they collect, and that there is really no bias at any level. Now, whether vascular surgeons, as previously Professor Zamboni mentioned, are more familiar with the vascular system, and that's why they are finding more objective anomalies than those who probably did not look that before, like the neurologist, especially respect to venous system, may be one of the reasons. As you know, before we started this work, we felt that it was very important to contact Professor Zamboni, and we really went through numerous trainings over, and in some media I was even, categorized as being Zamboni biased, right, Paolo? Although I thought it would have been important to learn what other people know, and then go with my feet forward and create a large study to apply in a multimodal way all these techniques. But one thing to answer finally your question and to keep the time on, if the Ccsvi is true, there is no way that it will not be confirmed, because really the amount of information coming from really 15 different modalities are pointing to the same point. That's what you want if the condition is real. And I think in our hands, really outcomes that we are using are pointing that this condition exists. Now, whether it's severe or it's mild depends on different subjects you are looking, but it probably exists in many, many people.
Thank you. Thank you, sir.
May I have another one or no?
Well, if you can make it focused and quick, and if the answers can be focused and quick.
I will just direct this to Dr. Zamboni. It's something that Dr. Laupacis had just said, and you weren't in here. He said after venoplasty, the narrowing occurs in the months after the treatment in a considerable number of patients, between 30 and 45%. This is an important limitation to the procedure.
So your question is,
is that
yes. Dr. Zamboni, did you heard the observation? Could you comment, please?
Yes, I think that this is true. So we tried to investigate the possibility to restore the flow by a simple, conservative, and safe methodology, that is venous angioplasty by balloon. But probably there are some presentation of the Ccsvi condition where this kind of procedure, very simple, probably does not work properly. So in the randomized control trial, my recommendation is to understand and to subdivide in the follow-up the clinical results in people who had the repair of the condition respect to people that do not have the repair of the condition. This is very important because really we are using a very simple device that probably in some presentation of the condition are not good enough to restore the flow, to fix the flow coming from the brain. We need to know exactly what is a proportion, because this was never done, and the proper tool again is to perform randomized controlled clinical trial.
Thank you very much. Senator Seth, to be followed by Senator Martin, to be followed by Senator Dick.
Thank you, Chair, and thank you all doctors here. I think it was such a great knowledge given, and I must say Senator Sidman has already given such a vast question was asked that this MS is such a debilitating progressive disease. The patient do suffer, and I think we need a clinical trial which we are going through so that we can achieve a good outcome and our patient can lead a normalized life. So my question is with Laupacis, that you have been at the St. Michael Hospital and you are the Canadian Institute for the Health Research Expert Panel, and you have concluded that there is a positive association between Ccsvi and MS, but the your result say did not allow definite conclusion to be reached. Please explain why not.
Dr. Laupacis.
So let me just make one correction at the beginning. Our research was funded by the Canadian Institute of Health Research, but I am not and have never been a member of the CIHR expert panel. The results of the summaries of the world literature that my group does is forwarded to the expert panel as well as other people, but I am not and never have been a member of that expert panel. To answer your question, I think as we did find when we looked at all of the 11 studies that many more studies found more Ccsvi in people with multiple sclerosis than in healthy controls, and that's why we said that when you look at the average studies, or if you average the studies, there is more Ccsvi in people with MS. But as I said, Dr. Zamboni's initial study found Ccsvi in 100% of patients with MS and 0% in healthy controls. We had another study that found no Ccsvi in any patient. So it seems to me when you have that degree of variability, and Dr. Zivadinov, who trained with Dr. Zamboni, found results sort of in the middle. Around, I think it was 56% of patients with MS had Ccsvi, and around 30% of people with healthy controls had Ccsvi. So when you have that degree of variability in the results of a test, it seems to me that we can't be certain, how to interpret the results. That's why our group concluded that we still, at least looking at ultrasound, don't know whether Ccsvi is truly associated with MS. And in particular, what are the things about the ultrasound that make the results from one study to another so different?
Okay, just quick second question. For Dr. Zamboni, you have been doing a quite extensive research. What have been the biggest obstacle to your research?
Dr. Zamboni?
Yes, the main obstacle was to project the randomized control trial, because after our first observational study, we immediately asked to move forward by a randomized control trial. But this is a very expensive kind of study. We do not have, of course, something like drug company or device company on our back to push this kind of study or to fund this kind of study. It was very difficult to convince at political level the importance to perform this study. It was a very long procedure, and also to have a shared protocol by the interdisciplinary steering committee was a very long work, because we have neurologists, neuroradiologists, interventional radiologists, vascular surgeons, so different minds, different way of thinking and way of describing the right protocol. It was a very, very long and very tough agreement to reach a shared protocol between the members of the steering committee. But now this work is finished, and really I look with faith to the possibility of perform this kind of study, because I believe that may give us the answer we are looking for.
Thank you very much.
Thank you.
Senator Martin.
Mr. Chair. Thank you so much. I'm someone who is keenly interested in looking at the risk factor and the percentages in that. From my own experience with my father, he fell into that small category of individuals that always was subject to these risks, and so even if it's 1 or 2%, I'm just so mindful of the impact, and especially if it's so fatal. So my question is regarding the process that was followed in Canada for the clinical trials that will be undertaken, and how important the peer review process would be. So Dr. Zivadinov, I know that you were a member of the peer review selection committee. Would you speak about the impeccability or the thoughtfulness of that process and what you selected, and I guess what you've all talked about today about importance of, same outcome measures and how there's just such disparity, and even within Italy, Dr. Zamboni talked about why he opted out of the study by the MS Society of Italy, that these disparities are there. So would you speak about the peer review process and what we have selected, and certain guarantees that our listening public, including ourselves, can have that what we're doing is going to be very, very important for the understanding.
Thank you for this question, Senator. I was one of the 8 members, I think, on the panel of CHR who evaluated different proposals that have been sent. The proposal by British Columbia was one of the best, because really planned a very meticulously training period for performing this type of procedure. It had really a very good basis for diagnostic of CCSVI, which was done through the first funded study by NMSS Society of Canada, and they really planned very well to both the treatment arms as well as treatment outcomes in a very, I would say, detailed and standardized way to be applied. It's also a multi-center study, so I think that it's very important to show that this type of procedure can be done at different sites and not just in British Columbia, and the investigators are very well known to the field of multiple sclerosis, and I think that they assembled a very great team together with vascular surgeons. One thing that Professor Zamboni mentioned, and I completely agree, and that's why Buffalo produced so many studies, that we are neurology. I am in the department of neurology, and I definitely advise to all those people who are studying CCSVI and are on the vascular side of the story that they cannot do it alone. They need to have participation of the neurologists who are experts in this disease. And in our case, we needed the experts on vascular side, and that was something that was found in our center, clearly in the Buffalo, and we really had a very great teamwork. And one thing to turn back to this proposal is that really an important teamwork has been awarded this study, and I hope that they will be able to answer some important questions.
Senator?
Okay, yes. So my question, not so much a question, but what all of you have talked about, how important it is to try and have some move toward standardization and harmonization and consensus and so on, because it is a global effort and arena now where there are so many jurisdictions that are undertaking their own trials. And so for Canada, would you say that going forward that we do have enough communication and exchange of information that we will be looking at sort of a greater standardization and harmonization?
I'm going to remind our committee that a large part of that has been answered. So if you will just focus on it, because all speakers talked about the ascension, especially Dr. Zamboni, about
I
the
think
need to bring it together. And I wonder, Dr. Zivadinov, if you could pull that together.
I think, as many MS patients are watching us today, probably it's very important for them to give the message that I repeated and repeated over and over. While patients might be impatient, to get the treatment immediately, I would agree with my colleagues that we need to show whether the treatment is appropriate and it's effective. And that's why we need to do this trial, and that's why we need to wait that time until this trial are done, because the last thing everybody in this room wants is to learn that the treatment might be harmful, right? So at any level, from side effects to serious adverse events to even treatment outcomes.
Thank you very much.
Yes, thank you.
I'm going to move to Senator Dick, to be followed by Senator Enverga.
Thank you, Mr. Chair, and thank you, gentlemen, for your wonderful presentations this morning. Very scientific, and it shows the degree we really are in the infancy stage of understanding the role of CCSVI in MS. But I want to focus my questions on the bill that is before us today, and particularly with regard to two aspects of the bill. Dr. Zivadinov, you mentioned that MS patients are watching us, and it's clear that MS patients have gone for CCSVI treatment, and some of them are being refused treatment. And the bill proposes that we ensure that there is follow-up care for persons who seek or have had treatment for CCSVI in or outside of Canada. And my question would be to all of our presenters this morning, do you agree that that should be set up? And the second part of that would be, do you agree that we need to have a national registry that tracks individuals who have received this in the event that there are adverse side effects and those kinds of things? So
I'll go to Dr. Zivadinov first, and then if the others wish to comment.
I completely agree with the bill. I think it's not ethical, first of all, that patients are not assessed, and that treatment, that assessment of the treatment outcome is refused or rejected. And second thing, absolutely, you need a national registry. You need to see how these patients are doing. So to be short, absolutely yes on both things.
Dr. Laupacis, do you have anything to add to that?
Yeah, I for sure agree that it's totally inappropriate for the people in the healthcare system not to see patients that have had the procedure elsewhere and not to provide them care. And I would hope that we don't need a national strategy for that, but the provincial healthcare systems and the physicians that work in them will simply do that. And I guess a registry would obviously provide useful information, particularly about serious long-term side effects. As I said before, I'm actually skeptical that a registry will provide much information about the benefits of treatment, and I think for that we need a randomized trial. And I guess here I have my hat on as a person who's a general internist and sees people with cystic fibrosis and sees people with any number of diseases, and I sort of think, a registry will cost a lot of money. I think we need to very carefully think, if we put a registry together, what information is going to be collected, how can we make sure that we collect it reliably, and I'm not sure that it's quite that straightforward, and I think we need to think about the equity for many patients with other diseases as well.
Senator Dick?
Nope, that's it. That's the only questions I had.
Well, I thought the question was aimed more at the Canadian situation, but Dr. Zamboni, would you like to make a comment on this?
Yes, I think that in general, the registry is a very good tool, but in this case, I think that cannot help very much because we do not know exactly what is the procedure performed outside. So sometimes I look to reports and I see that the adagos vein, for instance, is never treated. But in my experience, in this vessel there are a lot of abnormalities and needs to be treated, especially for the motor disability. So the registry is very good if you should have a shared protocol of treatment outside. Otherwise, I think that in this phase is better in RCT.
Thank you very much, Dr. Zamboni, and I'm sorry I didn't recognize your intervention. Senator Dick, further?
No, that's all. Thanks.
Thank you. Senator Verga.
Thank you to all our presenters today. I really appreciate all your coming here and being on the other side. Anyway, I know that this topic is being getting some international attention, and it's so important for all our MS friends out there. My question is: a few months ago, the U.S. Food and Drug Administration, the FDA, issued an alert about the potential dangers of the Ccsvi. Dr. Siskin, expert from Albany, recently said that, if I may quote, although the studies published to date seem to provide the necessary support for the off-label use of these devices in clinical practice, they do not adequately answer the safety and efficacy concerns raised by the FDA and the neurology community. Could you please comment on the FDA's warning and on Dr. Siskin's recommendation, if you may, please?
I'll go to Dr. Laupacis first, then Dr. Zivadinov, and then Dr. Zamboni.
Well, my interpretation of what the FDA said was, there's some really rare but serious side effects of venoplasty, and I think we all agree with that. And I would simply agree with Dr. Zivadinov that this procedure should be done as part of randomized trials.
Yeah, I think I agree. I think that FDA had to come in advance and say you can't, put the devices that are not approved for this type of pathology, right? And I think it was right thing to do it. I don't think actually it was very helpful that more kind of order is going to happen after this decision, but I don't think that this decision in any way is decreasing ability to conduct the trials on Ccsvi. With as a matter of fact, just to give you an idea, when we have any investigational drug, we are always applying to FDA for so-called IND, which is investigational new drug, and we are getting the approval or not approval, depends when and why and how. So I don't think that this is nothing strange, really.
Thank you. Dr. Zamboni.
Quickly, I think that FDA take into account more than 20,000 procedures that was performed and with devices that was sold to people without any validation study paid by the company. So the warning is more to the company because they sell devices and do not perform any kind of safety study, do not pay and support randomized control trial to assess the safety of the devices. I think that, in my opinion, the warning is not for the investigator, it's for the company.
Thank you very much.
And do you have a plan to work with the FDA at this point with regards to this study?
Yeah, I mean, we are finishing our study, and our study was really early designed, but we definitely registered our study with the clinical.gov.
Thank you. Senator Eagleton.
My question is to Dr. Zamboni, since when I had asked my previous questions, he hadn't yet arrived. So, and it's a follow-up to what Senator Merchant asked about earlier. Because I think, just as a preamble, we have to bear in mind that while these clinical trials are going on, people are still going to seek this procedure. People with MS are going abroad. They can't get it in Canada. They are going abroad, and they are getting this procedure done. And, of course, we're hearing a lot of stories about it. But the one thing that Senator Merchant mentioned earlier is the statistic that after venoplasty, the narrowing reoccurs in the months after treatment in a considerable number of patients, between 30 and 40%. Now, what can be done about that? I mean, there people get up their hopes, they go, they get the procedure. A lot of them come back and they're talking about the wonderful new abilities they have to do things, and they're so enthusiastic. And then this narrowing can reoccur in a number of cases. What can be done about it? Does it mean a further procedure, or does it mean there has to be more discretion used in who gets the procedure to start with? Maybe some people are getting it that shouldn't be getting it. What do you suggest here? Because people are going to go out still and try to get this procedure even while we're waiting for the clinical trials.
Dr. Zamboni.
Yes, we reviewed our cases of recurrences very carefully. And what we discovered that there are preoperative conditions that can be seen preoperatively with adequate and a deep investigation that clearly show and predict what are the best candidates to the venous angioplasty respect to people that probably needs of other kind of treatment for their CCSVI. For instance, the more frequent condition linked with ineffective treatment, because it's not recurrences, is simply ineffective treatment. The balloon is not enough. Are mainly two. One is an entrapment and compression by muscle in the neck, especially the digastric and the omohyoid muscle, that can be temporarily solved by the balloon angioplasty, but they recur because there is an anatomical relationship between the muscle and the vein. Second is a very, very long intraluminal membrane or obstruction that cannot be disrupted by the inflation of a balloon and simply recur after the vein regain the previous cross-sectional area. This condition can be really seen before the treatment. And if someone should be so careful to perform research, may see the same things and give correct indication to people who want this kind of treatment.
Dr. Zivadinov?
I think it's critical to establish monitoring screening tools after the treatment to determine whether the restenosis occur. For sure, these are not invasive, because you are not going to put your patient every month through catheter venography, which is, as we all agree, very certainly not a simple procedure. In our hands, use of Doppler in trained hands is a very good tool, but yes, the restenosis occurs. We have no experience with reapplying the procedure, but from what I read and review, I think it's very dangerous, and I do not recommend to obtain another reopening of if the first one didn't work. Because you can even collapse the vein by second procedure, and I don't think there is. And most of the safety issues that happened in open label are from the repeating of the procedure, from what I understand.
Dr. Laupacis.
Nothing to add.
Thank you very much. Art? No?
A little one?
No.
Well, you go. You.
Well, actually, if you have a really specific question, I wanted to try to pull together some of the things we've heard.
I just have a very specific question, and it's a question of I need education on. We're talking about endovascular treatment, but my understanding is venoplasty or stenting are both that kind of treatment. Now, are all the statistics and all the information we're talking about is completely venoplasty as opposed to stenting?
Yeah, I think this is an excellent question, and I think that I wanted to, but there was no chance to comment when we discussed about 1 to 2%. I would say that if you exclude the stents, probably the prevalence of serious adverse event is going to dramatically decrease.
Oh, really?
Okay, because most of the serious adverse events really have been linked to the use of stents, and from the beginning, neither Professor Zamboni, neither us recommended use of stents for this condition. Now, the problem with the venoplasty is obviously, as has been said, the atrial fibrillation and really the non-efficacy and repeat of the restenosis. So I think that probably the prevalence is much lower when the stents. And another important point, very briefly, if you really think the arteries should always be open to bring the blood to the brain, but with the veins it's a really different condition, because when you lay down, these jugular veins close, right? Because the vertebral system, when you are in an upright position, the jugular veins are closed because the vertebral system is draining mostly the brain. So by artificially changing the status of the vein, not in a physiological manner by using stents, you are altering a normal condition, right? Why somebody should have open jugular vein in an upright position. So I think there is really more to learn here how the treatment should be done.
Thank you very much.
Thank you.
I wanted to bring together just a couple of things that you have. Well, first of all, I'm going to say on behalf of the committee, I think it's remarkable for us to have such a level of expertise covering the various ranges of such a new and emerging concept and the potential application of the concept and its implications. And you have been exceedingly helpful in explaining to our committee these serious and complex issues that go into the actual medical side of what is actually going on here. And I think you've been able to give us the ability to interpret your remarks in a way that will be helpful to us in dealing with this question. And I think it's exceedingly, I was impressed by the fact that all three of you stressed the critical importance of the double-blinded clinical trial study with clearly defined measures and hopefully perhaps some international consensus on how to what to look for and to contribute, as Senator Martin has suggested, that information together so that perhaps a conclusion can be reached more quickly than if we just have a series of studies. I also thought it was important to us that you raised the issue of the risk factor. We've been dealing with this, and up till now, with regard to the drug side of the issue, we have simply heard numbers of people who died from the use of Ccsvi, for example, without putting in the context that you have identified that it's clearly important to identify the risk factor. That is, how many serious adverse effects occur per patient treated at the same level. And because it's come up several times, I looked into the detail, and Ccsvi is apparently applied to MS and Crohn's disease and some other areas. And in all those patients that are studied, the patients who have all three of those conditions, those would be very seriously afflicted persons, one would expect, the risk ratio is 1.1% in those categories, which would fall into the range, I think, that you were discussing with regard to the figures that you gave here. So I thought it was really helpful to us that you made that point about its risk factor. It's not the singly the number of events. It's how you interpret those against the issue. And so to all of you, and Dr. Zamboni, I want to go back. I want to go back to you and to say to you that I can't tell you how much our committee appreciates the fact that you took the degree of effort you did on a holiday in your country, to travel considerable distance. Some of us think that auto travel in Italy is not necessarily the easiest thing to achieve, and on holiday it's probably extra special. So we want to not only thank you for being here as the person whose name is associated with the issue that we are all trying to study, but that you took this extraordinary effort. To Dr. Laupacis, I know that it was difficult for you to be able to be available for this meeting, and yet you were, and fortunately you've been able to stay through the meeting. So I know my colleagues are really appreciative of that. And, of course, our third expert, you're all world experts in this particular area. You've all made major efforts to be able to be here. Dr. Zivadinov, you drove from Buffalo, I understand, to Canada, took a flight to get here this morning, and I don't think it's possible for me on behalf of the committee to thank you all enough for being here, and I know you've contributed enormously to our understanding of the issue. And with that, colleagues, I declare the meeting adjourned.